Good evening, good afternoon, and good morning from Ann Arbor, Michigan, to everyone joining us from around the world. My name is Dr. Fernando Farking. On behalf of the Michigan Language Assessment Team and all the organizations participating in this event, I'm pleased to welcome you to the opening session of Michigan Language Assessment's online symposium, Global Solutions to the U.S. Nursing Shortage, Policy, Recruitment, and Collaboration. We're delighted to begin this symposium with a truly global audience, with participants registered from more than 45 countries. Thank you for joining us for this important conversation. Our first panel is titled Global Nurse Mobility and the U.S. Workforce, Trends, Data, and Policy Implications. This session will examine global nurse migration patterns and how they intersect with U.S. workforce demand. We'll focus on current mobility trends, shortage specialties and geographic distribution, policy trends, and workforce planning implications for communities with significant healthcare needs. Before we begin, a few quick housekeeping notes. Today's panel will include brief presentations from each panelist, followed by a moderated discussion and a Q&A session to answer some questions from the audience. The topics and discussion questions for all the symposium panels were shaped by the questions many of you have submitted during registration, so thank you for helping us guide today's conversation. If you have additional questions, use the Q&A function, please. Keep them brief and relevant so we can address as many as possible. And the symposium is being recorded, so we will be sharing the recording with the registered participants after the event. So now I'm pleased to introduce our panelists. Joining us today are three distinguished experts who bring complementary perspectives on nursing workforce data, regulation, mobility, and policy. First, we have Dr. Michelle Washko, Director of the National Center for Health Workforce Analysis at the U.S. Department of Health and Human Services. Welcome, Michelle. We're also joined by Dr. Brenton Martin, Director of Research at the NCSBN, the National Council of State Boards of Nursing. Welcome, Brenton. And Dr. Lauren Herkes, Senior Director of the Center for Global Research and Policy at Geographic. Thank you all for being here. I'd like to invite each of our panelists to briefly introduce themselves. Please share your name, your role, what part of the global nurse mobility or U.S. workforce your work touches, and one barrier you think is most solvable. Let's begin with Dr. Washko, then Dr. Martin, and then Dr. Herkes. Michelle?
Yes, hi. Thank you so much. It's really lovely to be here. As you mentioned, my name is Dr. Michelle Washko. I am the Director of the National Center for Health Workforce Analysis. In that role, I am supposed to be an expert in the entire healthcare workforce in the U.S., which I am. But obviously, nursing being the largest is an area that we focus in quite a bit. And because we are really mandated to examine the U.S. labor force, we are very quite intimately concerned with international issues of migration and shortages and other occupations beyond nursing as well. What was your last question? I forget now. It's the barriers, right? Barriers to it. I think policy. There's some policy issues right now that I think we'll probably end up talking about that would be the biggest barriers. So thank you.
Perfect. Dr. Martin?
Hello, everyone. Thank you, Fernando. As Fernando mentioned, my name is Brendan Martin, and I am the Director of Research at the National Council of State Boards of Nursing. I'll endeavor to keep that a little bit simpler for today's conversation and just simply refer to it as NCSBN. I'm here today to discuss trends related to U.S. workforce entry, specifically the licensure exam, which you all know as the NCLEX RN. One barrier that I think is most solvable, and I thought that this was kind of a really interesting prompt, is if there is the will, and this may shock many of you, I think one solvable issue is really the historic levels of nurse burnout that we and others have documented since the onset of the COVID-19 pandemic. Why, you might ask? I assure you it's not because the answer is simple, but it's because the solutions are easy, but it's because the solutions are known, I would argue, meaning we can identify with a fairly good level of confidence the primary and persistent drivers of nurse burnout, not only since the onset of the pandemic, but also over time. I'll be happy to elaborate on that a little bit in the course of this conversation, but for now, suffice it to say, I'm grateful for the opportunity to participate today, and I would just like to thank the Michigan Language Assessment for the invite.
Thank you. And Dr. Herkes?
I'll echo the thank you for having us here today and repeat that I'm Lauren Herkes. I'm the Senior Director of the Center for Global Research and Policy, which is part of TruMerit's Global Health Workforce Development Institute. At TruMerit, we serve global nurses and allied healthcare workers with credentials evaluation and career mobility. So I can speak to the global context for the US nursing shortage. It's hard to choose one barrier. Like Brendan, I think that a tractable barrier that we can address is participation in the Alliance for Ethical International Recruitment Practices. Ethical recruitment is a significant challenge, and there are steps that people can take, that organizations can take to ensure a safer and more ethical recruitment experience.
Well, thanks to the three of you. So we'll have short presentations from our panelists. Before we move into the presentations, we'd like to invite the audience to respond to a short live poll. Riley, if you can run the poll now. The question is, what are the primary challenges to international recruitment of foreign trained nurses? We want to hear what you prioritize in that area. So we'll look at the responses when we finish with the presentations and see how we agree based on the information that the three panels will be sharing. So, Dr. Washko, would you like to start with your presentation?
Absolutely. I'll start sharing my screen. Okay, hopefully you can see this. Oops.
Perfect.
So,
yes.
Great. So as you know, as you mentioned, my name is Dr. Michelle Washko. Here it is again. And today I will be discussing trends in the US nursing workforce with a particular focus on supply, demand, and the challenges we face in addressing workforce shortages. While my remarks are going to focus on the US, many of these trends, especially around workforce shortages and aging populations, are relevant globally. To begin with some context, the US healthcare workforce is very large. Nearly 18 million people were employed in healthcare in 2024. Healthcare also represents a significant share of the US economy, accounting for about 17.6% of our GDP. Despite this scale, we have continually faced persistent workforce shortages in nursing and other occupations, and massive challenges with distribution, meaning that some areas have far fewer providers than others. At the same time, demand is increasing, largely driven by an aging population that requires more frequent and more complex care. Nursing, as I mentioned, is the largest health profession in the US. Our national sample survey of registered nurses found that there are about 4.3 million actively licensed registered nurses, with roughly 3.5 million actually working in practice. Looking more broadly, the total actively working nursing labor force, which would include licensed practical nurses and advanced practical nurses, practice nurses, is more around 4.28 million. Growth has not been uniform across these different roles. We've seen strong growth when it comes to nurse practitioners, nearly 40% over the past few years, while the number of LPNs or licensed practical nurses has declined. These shifts are important because they influence how care is delivered across various settings. Looking ahead, one of the things my center does is we are responsible for producing workforce estimates and projections for the entire US and as many healthcare occupations as we can. Our national projections, which we update annually, show continued pressure on the nursing workforce. Just in the past 6 months, we are predicting that by 2038, we're going to have a modest shortage of registered nurses, about 3%, which is roughly 109 full-time equivalents across the entire US. That situation is actually more severe for LPNs, where we're looking at around 30% across the entire US. And nurse practitioners, it looks like supply is going to meet or exceed demand. But the important thing here is actually not those hard numbers or percentages. It's that the national level balance doesn't mean local adequacy. Distribution has always been our key challenge. There are massive imbalances at lower and lower geographic levels. This bar chart highlights one of the most important issues, which is that geographic disparity issue. While the overall national shortage for registered nurses may appear relatively small, as I mentioned, 3%, that average masks significant differences between regions. So in this case, I'm contrasting rural, non-metro, versus metro or urban areas. And what we see is that the rural areas are projected to experience much higher shortages than urban areas, which reinforces what I've been saying, that workforce challenges are not just about how many nurses we have, but actually where they go, where they're located. To build on that point, more specifically, by 2038, we are going to see an 11% shortage of registered nurses in the rural area, non-metro areas, compared to just 2% in metro. We also see substantial variation across the states. For example, states like California and Michigan, as you can see, we are projecting to face particularly high shortages. So a 22% shortage of nurses in California, 18% in Michigan, and so on. These patterns highlight the importance of targeted place-based strategies, especially for rural and underserved communities. Now, it's important to note, of course, that demand for nurses is not uniform across specialties or settings or geographic locations. We're seeing especially high demand in areas like medical surgical care, critical care, emergency services. And at the same time, long-term care and home health are experiencing growing pressure because of our aging population. As people are living longer with more complex conditions, the need for nursing care increases, not just in hospitals, but across the continuum of care. Demand is also particularly high, as I mentioned, in underserved communities where access challenges are already incredibly significant, especially with the numbers of rural hospitals that are closing. In addition to supply and demand, retention is a critical issue that drives shortages. As Brendan mentioned in his earlier comments, recent data show that about 41% of nurses report an intent to leave their positions in the next 2 years. We saw workforce exits during the pandemic at about 5% leaving the profession, and burnout is a continual major concern and has lasting impacts on workforce stability. That means that recruitment alone is not enough. We also need to have effective strategies to retain the workforce that we have once we get to where we need to be. This includes improving working conditions and financial incentives that will increase retention. However, the most immediate changes that we can make to address shortages, of course, are concerning the pipeline. There were over 230,000 newly registered licensed nurses in 2024. We're seeing modest increases in entry-level bachelor's degree enrollment in the US, which is encouraging, but there are some concerning signals. For example, there have been some decline in NCLEX international candidates and pass rates in recent years, which, again, I know Brendan is going to address. And overall, the bottom line is that the key challenge is ensuring that the number of new entrants to the nursing workforce is sufficient to offset retirements and ongoing attrition from that same workforce. The international nursing workforce is certainly a part of that solution, something that Lauren's going to be telling us about in depth. But this has to be accompanied by careful planning. Destination countries like the US need to do what we can through our policies to make sure that we're not worsening the shortages in other countries. And with that, I would let you know that if you have any questions about any of this information, please feel free to go to our website. And if you'd like to follow up, happy to do so. Thank you so much.
Thank you, Dr. Washko, for helping frame this workforce landscape and the data behind the current and projected demand. Lots of interesting comments here. Next, we'll hear from Dr. Brendan Martin.
Thank you very much. And, as I go to share my screen, the first thing I'll do is I'll immediately go off script and just say, in particular, to the intent to leave projection and the issues of persistent burnout, I would just say amen to what Michelle said there, because it's something that we see in our work all the time. And I think it's a really critical, long-standing issue, but certainly has been exacerbated since the onset of the COVID-19 pandemic. So for those of you who are perhaps a little less versed with who we are and what we do, I'd like to begin by sharing a bit about our core purpose as a research team at NCSBN to really kick things off. We're a small group, but we're here to advance the science of nursing regulation by generating valid and reliable evidence that informs decision-making primarily for nursing regulatory bodies around the country in support of their mission of public protection. We're a full-service research group providing end-to-end services from design, analysis, and reporting, and we really zero in on a whole host of issues. So today I'll be discussing some trends associated with the NCLEX RN and the national nursing workforce, in particular the supply of nurses in the United States. But we also look at critical issues such as nurse mobility, education, discipline, and licensure. I am here, though, today principally to share a bit more insight into how recent international NCLEX RN candidate and select US workforce trends have really evolved primarily over the past decade. And in particular for international candidate trends, I'll zero in on the last half decade. Fun fact for those who are interested, all of the data that I'm going to share today are publicly available. So I'd really position these high-level results as just the tip of the iceberg, so to speak. If you are interested, this information is sourceable. There's additional context to this information, but I really just kind of wanted to walk you through some high-level trends. So with that said, let's just kind of jump right in. For context, I am here to talk about international candidate trends, but I think it's important first and foremost to really understand as the backdrop to all of this, first-time US educated candidate trends, both in terms of overall volume and pass rates over the last 10 years. So the reason I selected the last 10 years is these are all the years for which we have complete information, obviously only about halfway through 2026. As you can see from this graph, we have seen a steady increase in the volume of NCLEX RN candidates domestically. And while we did document some pass rate volatility really during the heightened phase of the COVID-19 pandemic, more or less we've seen steady pass rates as well. So if there was one way to kind of encapsulate the domestic snapshot for the last 10 years, it's kind of steady as she goes. And you'll see why. I'm going to zero in on this a little bit just to kick things off. Looking at repeat US educated candidate trends, however, we begin to see a little bit more obvious fluctuations, particularly a ramp up in the numbers beginning in 2021, which you can see from this graph peaked in 2022 and then really sustained a bit into 2023. Why, you might ask? I think Michelle offered some caveats to her data. I'll offer some caveats to our data. It is really difficult to precisely pinpoint the drivers of candidate fluctuations, right? You're trying to get at the motivations of individual candidates, folks who have recently completed their studies, et cetera, et cetera. So it's not really easy to batten down exactly what is the primary driver. And frankly, it's outside of the scope to definitively draw specific conclusions. However, with that all said, one meaningful inflection point that does coincide with this trend, and it will likely not come as news to many in this meeting, was the launch of the next generation NCLEX in spring of 2023. For this graph, remember, these are repeat test takers. So these are individuals in advance of 2023 who had taken the NCLEX licensure exam prior. And one hypothesis that I think one could reasonably form, given the other issues and factors at play, is that they sought to retest prior to that transition. But again, major caveat, this is just one possible driver. With the domestic candidate trends as the backdrop, though, we really transition here to looking at the international educated candidate trends. So this particular slide, you can immediately see, in particular, vis-a-vis the domestic candidates, a much more pronounced trend among first-time internationally educated candidates, particularly as it relates to candidate volume. So it's those green vertical bars. Over the past 5 years in particular, we have documented a pronounced increase in the number of first-time internationally educated candidates, particularly beginning in 2022. This again coincided, right, with the launch of the next generation NCLEX, but also investment in opening new international test centers. These factors, almost assuredly among many others, have helped drive a 2 to 3-fold increase in first-time international candidate volume over the last 3-year period. Notice, though, and I think that this is always important to really ground our understanding of candidate volume, the pass rates here have held relatively steady. There has been a little bit of a jump up in the most recent years, but it's kind of come back down where you can see in 2021 and 2025, respectively, they were at the same pass rate number. And what is particularly important to recognize is that a smaller proportion of international candidates compared to their domestic candidates, their domestic counterparts, actually pass the NCLEX exam. So when you think about implications for the workforce, yes, of course, candidate volume is the kind of the tip of the spear, but we also have to recognize that immediately that funnels down to about a 50% pass rate. As the two are linked, It's not surprising at all to see a very similar trend emerge for the volume of repeat international educated candidates. Again, beginning in 2022, we see that trend kind of start where there's a little bit of an increase, and that peaked really in 2023. Same, potential drivers there with international test centers and the launch of the next generation NCLEX. But importantly, remember that the latter, meaning essentially the first time international test takers, has inevitable consequences as it relates to repeat international test takers as well. So when we get into the repeat context, an increase in the volume of first time test takers will naturally result in an increase in the number of repeat test takers as well. So what we have seen is overall a very similar trend among repeat test takers, where we've seen some of the highest sustained numbers among this cohort of individuals over the last 3 years. Regardless of the lower pass rates, an increase in candidate volume has inevitably led to a recent spike in the number of international candidates who have passed the NCLEX, again, particularly in 2023. This has resulted in a 2 to 3-fold increase in the number of international test takers who, based on their exam success, are now eligible to enter the US workforce over the past 3 years. Not all countries are created equal, though, and I know Lauren is going to touch on this. As you can see, the Philippines alone accounts for nearly half of the trend associated with those who have essentially qualified for entry into the US workforce. So what does this mean for the workforce? This is where Michelle and I intersect a little bit with HRSA's NSSRN and our National Nursing Workforce Survey. I think that the simplest answer when you look at the implications in international candidate volume and the recent increase for the US workforce, the real short answer to drive right to the heart of it is that currently and transparently, what this means for the composition of the US workforce is TBD, or to be determined. Over the last 3 cycles of our National Nursing Workforce Survey, which really bookend the COVID-19 pandemic, you can see there 2020, 2022, and 2024, we have seen significant fluctuations in the share of the US workforce that is composed of internationally educated nurses. The same dip that we documented among this cohort, we documented among the overall workforce at multiple licensure levels in 2022 as well. So while it is true, and I want to highlight today, that we documented with a margin for error, of course, the largest share of the US workforce being internationally educated in 2024. The preliminary nature of these findings really does give us pause in projecting future increases, as so much of the recent volatility wrought by the pandemic is really, as of yet, still unclear, meaning what constitutes the beginning of a trend, let alone a durable trend, is still far too early to pinpoint. One thing is for sure, the pool of international candidate NCLEX RN candidates and those passing the exam has increased in a very pronounced manner over the past 5 years. This has obvious implications potentially for the future US workforce, but what is equally apparent is that not all of them are currently entering the US workforce. So one project we do have on our horizon in collaboration with our colleagues in the examinations division here at NCSBN is to definitively identify what share are entering the workforce, and as best as possible, what are the others using this credential for, if not to enter the US workforce. I think that that's still kind of a remaining answer. But for now, that is it for me. Thank you, and I will turn things over to Lauren too. I can stop sharing.
Perfect. Yes, thank you so much, Lauren.
Thank you. All right, I'm going to try and contextualize some of the data that my colleagues just described with respect to global patterns and how those intersect with demand in the United States. So we just heard about the current and projected nursing shortages in the US and about how maldistribution is a critical problem. Well, this same phenomenon plays out on a global scale. Our most recent estimates indicate an aggregate global nursing shortage of 5.8 million nurses, which is projected to drop to just over 4 million nurses over the next decade or so. But the distribution of nurses around the world is extremely lopsided. In some nations, there are more than 100 nurses per 10,000 people, while in others there are fewer than 10. Over the past decade, we've seen big gains in the growth of the global nurse workforce, with some of those gains accruing in nations with the greatest need, although more of the gains have taken place in nations with less severe shortages. Today, nearly 4/5 of nurses around the world work in countries that contain less than half of the global population. Addressing the global maldistribution is a really sticky challenge. Often, the places facing the most severe shortages lack both the educational system capacity to produce more nurses and also the health system capacity to hire more nurses. So currently, 1 out of every 3 nurses is educated in the Americas and Europe. 1 out of every 7 nurses works in a country other than that where they were educated. So the flow of nurses around the world has also been a little volatile over the past decade. Today, more nurses migrate to Europe and Southeast Asia, and fewer nurses migrate to the Eastern Mediterranean and Africa than they did a decade ago. But individual nurses who move internationally move for many different reasons. Many of these are very consistent over the years, as people of all backgrounds who decide to migrate have many of the same considerations in mind. They might be seeking higher pay or better working conditions. They might be looking for professional development or professional advancement opportunities. They might move so they can better support their families, either by living closer to them or having the opportunity to send remittances home. In some local conditions like conflict and climate change might drive people to migrate. But international migration often flows from lower resource contexts to higher resource contexts, which can make the most severe shortages even worse, as Michelle alluded to earlier. Global nurse workforce shortages are projected to shrink in the coming years, but as the number of nurses rises, the global maldistribution is expected to get worse. Some of the most underserved regions will see the least growth, while some of the strongest healthcare systems will see additional growth. So keep in mind that growing the nursing workforce is only part of the solution. In the coming years, we project a growing demand, especially in places with higher levels of fertility, aging populations, or conditions that lead to a greater need for chronic care. So in aggregate, African and Eastern Mediterranean regions will only see slight decreases in nursing personnel density, and they're projected to bear nearly 70% of the global shortage of nurses by 2030. This is a greater share of the global shortage than was estimated before the pandemic. So, as compared with the projected nursing personnel growth, they would need to double their nursing workforce in order to close the shortage by 2030. So, as we just learned, more than 6% of the nurses in the US are trained abroad. If you review the most recent reports that survey the global nursing workforce, the World Health Organization State of the World Nursing Report and from 2025, or True Merit's 2025 Nurse Migration Report, you'll see that the top sending countries are the Philippines, Kenya, Canada, India, and Nigeria. You'll also see that the US and the UK are top global destinations for migrant nurses, which is a really interesting claim for me to wrap up my data summary with, because it speaks directly to a topic that I think we'll come back to during this conversation, the availability of data. So these numbers are from a World Health Organization report published in 2023 and based on data drawn from the WHO's National Health Workforce Accounts data portal in 2022, that top claim about the US and the UK. This is the last year for which there's complete data. It's really challenging to get information about nurses' training, professional mobility, and workforce transformation at a global level because that data is very challenging to develop and to obtain. The WHO relies on voluntary member state reporting, which is one of the reasons that more recent data is incomplete. So these data are the most recent that we have, but they're almost certainly a little out of date. In fact, we know about a year ago, the UK's Nursing and Midwifery Council began reporting a sharp drop in international recruitment and a corresponding slowdown of nursing workforce growth. It, over the previous year, had dropped to less than half of the growth that it had seen the previous year. So new immigration rules and policies are almost certainly driving some of that change. As of March of 2024, care workers in the UK were unable to bring partners or children with them. Application fees for healthcare worker visas in the UK went up to nearly £3,000, Minimum salary requirements were put into place or increased. So this is almost certainly one of the reasons we saw the growth experiencing such a sharp decline. US policy has changed a great deal in the past 6 months or so, and deprofessionalization and changes to recognize credentials for nurses and other health professionals will almost certainly impact the career paths of many nurses. Immigration policies under the current administration reflect new weighted selection processes for H-1B visa applicants. And in January of this year, the US State Department announced that it would pause all immigrant visas from 75 countries, including many high volume sending countries such as Ghana and Nigeria, effective January 21st of this year. But we don't actually have the data yet to describe the impact of these changes, particularly in global context. So that's a little bit of data to contextualize some of the trends that we see. And as others have said, I encourage you to reach out if I can answer any questions.
Thank you for the three very interesting presentations and connecting global research, Dr. Herkes, and all these different variables in ethical mobility. So we'll move on to the moderated discussion section. Before that, I will report on the results from the poll from the audience so far. The question was, what are the primary challenges to international recruitment of foreign-trained nurses? And of course, there's a big alignment with what you were saying in your data. The 30% felt it was due to turnover and retention, then 24% specialty shortages, and 20% geographic maldistribution. So thank you for those responses. So the first question I have for the three of you is to begin with demand in a way. Based on the data and trends that you have presented, what are the top shortage specialties and geographies driving international nurse recruitment now? And you've already touched on a little on this. And what do you expect to shift in the next 3 to 5 years? Who would like to start?
I'm happy to start with that one.
Yeah.
I think I mentioned that a few of them are things like med surg, critical care, but things that are driven by an aging population like long-term care as well, which we know is that particular sector is very much supported by the nursing profession. And in terms of shifting in the next 3 to 5 years, when I think about how to build a labor force, there's really three components. It's births, deaths, and migration. We're at historic birth rate lows in the US. Deaths, we are living longer, but people are not necessarily well enough or choosing to stay in the workforce longer. Could be burnout, could be a lot of the things I've mentioned that Brendan mentioned. And the last thing are migration policies, which we know are shifting and are going to continue to shift over the next 3 to 5 years.
Mm-hmm. Lauren, is there anything you want to add to that?
Only that I think it'll take a little while for us to develop the data to see the relationship for those impacts. And so a long view and historic analysis of policy impact can help us develop more rapidly applicable solutions, because we do know what some of the forces are at play. And some of these questions, like maldistribution across the US and globally, even though the quantities, the specific numbers will change, the phenomenon is going to be fairly consistent.
Yeah, and I would really echo what Michelle said too. You know, the three areas of need I would identify over the next 3 years would really be that acute critical care setting, long-term care, right there with you. We recently conducted a sub-analysis out of our 2024 workforce sample, and that will be being published in the American Journal of Nursing here shortly. The other piece of this, which Michelle really touched on in her introduction to those rural non-metro areas, or kind of more generally, I might even just say general provider shortage areas, because sometimes those can be metro areas as well. I think that that's what we're going to see. And, you know, I struggled with this one because I didn't want to be the pessimist in the room, but I ventured to guess I wouldn't be alone. Frankly, I expect the shortages in these three areas to actually just worsen in the next 3 to 5 years rather than to kind of shift. And I would point to what everyone is kind of talking about. You know, at NCSBN, we publish annually an environmental scan, which is really kind of a scoping review of the state of nursing. And a lot of things that we've touched on were really the focus of this most recent one. The aging population, of course, with that, longer lifespans, more complex needs. Something that Michelle hit on in her presentation, too, that I wanted to pick up on, modest pre-licensure enrollment growth over the last 5 years and the long tail effects of the pandemic on pre-licensure education. I believe in our most recent environmental scan, the American Association of Colleges of Nursing, or AACN, was cited as, noting about 6,000 additional pre-licensure students, graduate every year since 2020. So, certainly not terrible. But when that's the best thing you can say, that's not fantastic. It is not sufficient to keep up with demand. And that has consequences down the funnel. Looking at the modest NCLEX RN domestic candidate growth that I presented earlier, and I think coupling that with the fact, many entities, many of our partners in industry, in education, in government, have kind of zeroed in on the recent increase in international candidate pool. But as I was able to, I think, document, that funnel shrinks pretty quickly. And then even of those who are eligible to enter the workforce, they don't always do so. So I think that there's a lot packed in there. But I think it's, we're dealing with very complex challenges now. And I very much, if I was a betting man, which I am not, I would very much, put money down on those challenges really persisting into the near future. I don't think we've wrapped our head around the solutions for those just yet.
Mm-hmm. Thank you. So let's move on to a second question, like going from diagnosis to action. If you could change only 2 or 3 things in the next 12 months, if we can all have a crystal ball and you can have the power to change a few things to improve ethical and sustainable nurse supply, whether through policy, regulation, data, operations, what would it be and why?
I'm happy to go first. I would love to see more compliance with the Alliance for Ethical International Recruitment Practices. There's a certification process for recruiters who comply with that code, and it's based on the WHO's Code of Practice for International Ethical Recruitment. It's a way to build on processes that are already in place and expand to include more recruiters and to create a more ethical market.
Great, thank you.
I'm happy to jump into, maybe we'll do a little reverse order here. One of the things that I would really focus on, my area is research, data tracking, analysis, et cetera. And so in these types of instances, I thought that this was a really great question. I want to parrot something that our CEO, Phil Dickinson, says quite often, and that's that modern day workforce planning really requires modern day workforce tracking. And so what I mean by that is I think workforce tracking needs to be reflective of the state of nursing practice, really in the 21st century, thinking about a US context particularly. The Nurse Licensure Compact is undeniably a net positive for patient access, and quality of care. However, that does, lead to kind of, an obscuring of practice trends in the United States, I think, that cross-border care. And I think it ultimately limits insights into how nurses approach work and therefore patients experience the healthcare system and their perceptions of the shortages. And then the other thing that I would just mention, and I'm not going to harp on all the underlying components of it, but I think that the always challenging task of accurately projecting workforce trends, I think my colleague Michelle and her team at HRSA do an absolutely fantastic job, and I do not envy the Herculean task that is projecting 10 years out. But I also think that there's a reason why they update those 10-year projections very regularly. I think it's kind of like the game of whack-a-mole. There are evolving shortage areas by specialty, setting, geography. We've already talked about population aging. One of the things that was heartening for us in 2024 version of our National Nursing Workforce Survey is we saw really a kind of boomerang effect, a re-entry into the workforce of older, more experienced nurses. I think that that's a net positive for mentoring, for sustainability and kind of stability of the workforce, in particular in a context of heightened burnout. But how durable are those trends? And, then that's not even getting into all the shifting global and domestic, dynamics, population aging, et cetera. I think that there's a lot at play, but I think we need to somewhat rethink how we do workforce tracking. And I think that has implications for how we, project out need and project out supply.
Great. I don't know if we lost. Yeah, she's back. Thanks for coming back, Michelle. I don't know if you missed the last part from Brenda's response to that question, but is there anything you wanted to add to that question?
Yeah, just two things. I don't know if Brendan hit on this, but two additional ways domestically that we could change pretty quickly is one, increasing education capacity to train more nurse faculty in the U.S. And expanding clinical sites. It's another way to increase our pipeline. And a second thing would be improving working conditions, which I mentioned as a way to increase retention. I mean, it could be financial incentives via scholarships and loans, things like that. It doesn't necessarily have to be wages. So those would be two things that I could see in the next 3 to 12 months.
Mm-hmm. Perfect. Since the first questions are your introductions, you talked about policy, nurse burnout, ethical recruitment. These will be, and what you're talking about now will be themes that will be repeated throughout the entire symposium, throughout all 4 panels, it seems. My last question is, for this initial discussion, we'll get to some of the questions from the audience then. Moving on to focus on data. Brendan was addressing that briefly right before this question. What are the 2 most important data gaps blocking smart workforce planning and ethical mobility policy, and who should own the responsibility for fixing them?
I'm happy to take this one to start. I think one of the biggest problems that we see is really an ability to actually not track, but count nurses in the US. We have kind of 50 different state boards of nursing and 50 disparate ways of actually saying who is here and who is working in what setting. To contrast that with another occupation, physicians, we have this thing called an NPI number that the Centers for Medicare and Medicaid Services has. It makes it much easier to enumerate the physician workforce in the US. We don't quite have an equivalent for nurses in the US. So that to me would be one huge data gap. I think it's something that can either be done, it would definitely be done, I think, governmental partnerships, either state to state or state with federal, that kind of a thing.
Thank you. Brendan, would you like to add anything?
Yeah, I would revisit one component of my prior answer and then add a second. I think, again, thinking of nurse mobility and the way in which the NLC or the Nurse Licensure Compact really fosters nurse mobility across state lines, sometimes international lines, facilitates things like telehealth, which this is actually one of the first webinars on nursing practice that telehealth hasn't come up. I think it's a sign of the times, how far we've come from the pandemic. But, thinking about the way that we conceptualize and track and plan for workforce solutions, I think needs to be updated because, to Michelle's point, if we don't necessarily even know in what settings or, in what geographic locales, et cetera, nurses are, currently working, how can we hope to know if they are, what level of cross-border care that they're providing? And so I think, updating our workforce tracking to really map more directly to a kind of a 21st century workforce profile, I think is important. And then the other thing that I'll touch on again is policies and solutions and really employer-based strategies and incentives to encourage the re-entry to practice of older, more experienced nurses. That was one of the more alarming trends that we really saw during the COVID-19. There were 2 very kind of companion pieces that we saw emerge from the data. It was the heightened stress and burnout among kind of the younger cohort of the nursing workforce. And that was often paired with the fact that kind of the kind of middle to more experienced cohort of the nursing workforce had really been hollowed out somewhat prematurely. At a certain point, you can anticipate, increasing and kind of never tapering off retirement trends. But we really started that start out in kind of the early to mid 50, age range. And we have been heartened by the fact that in our 2024 analysis, we've seen some of those folks come back. I think it's really critical. And I think, I hear it in Lauren's talk, I hear it in Michelle's comments. I think, resting on our laurels would be a really big mistake. I think it's an opportunity to really, part of your question, your prompt was, who should really own this? I think at the end of the day, the only way to achieve, the scale of the solutions that we need is through coordination and collaboration. On this call, I'm sure we have educators, practice partners, certainly regulators, government, industry. I think if we're going to get at sustainable solutions here, it's only going to be working in concert with each other and recognizing that all of these complex problems have partial solutions from many different angles. So I would say, all of that, and then likely more. It's a complex issue.
Great. That will sure be one of the quotes we'll use in the report about the symposium. So,
Well, I'd love to
uh,
build on that. I really appreciate your focus on workforce data and considering mobility in particular. I know that the Nursing License Compact does many different things, including promote and permit mobility. Another thing that it does is enable us to start thinking about comparability, how we can think about those workforce profiles, not just the licensure or certification, but also the preparation, the training, the professional experiences, the kinds of competencies that individual workforce members have, and how those might be deployed more intentionally to parts of the country where they're most needed, where we could have some coordination between workforce needs and regulatory bodies and even educational organizations to match the skills and personnel with the workforce needs where they're most needed.
perfect. Yeah, that's why this symposium is based on policy, recruitment, and collaboration. That's exactly the idea behind getting together with so many different stakeholders here. So let's move on to the Q&A section and address some of the questions from the audience. Many submitted questions when they registered, are very interesting questions. So thank you for helping to shape the content of this, all the panels. One of the questions that several people asked about was, what do you think is the greatest barrier for internationally educated nurses who want to come to work in the US? You've mentioning several comments in relation to that. What do you think are the most important barriers for them? And we have other panels that will address that more directly later on, but it would be good from the point of view that you all three bring from your different perspectives, how you address this question.
I'll take it from the most basic point of view because it's the whole point of the NCLEX. It's qualifying to practice in the United States. I saw a question too come in the chat earlier about why the pass rates are so much lower for internationally educated nurses. Again, I'd hesitate to pinpoint just one thing. But for obvious reasons, the NCLEX is aligned, right, with the standards and the education that is here in the United States. What I would say is, when we look at that funnel, while we have seen a dramatic increase in the number of candidates, the pass rate has not increased. And so, I think that there's a tendency to look at, between repeat test takers and first-time test takers, it looks like we have 100,000 more international nurses who are potentially able to enter the workforce, but that number narrows very, very quickly. And so I think part of the solution from my perspective is to try to understand how these international nurses who do qualify for entry into the US workforce, why maybe they are not coming here, and what share are coming here, because I think that would really help us kind of nail down what is the current context as it relates to those trends, but then also help us understand if international recruitment needs to be kind of a component and one of the possible solutions, to some of the shortages that we experience here in the US, which I think Michelle did a really nice job of laying out, then understanding what they're doing with it when they qualify for entry here but don't come here is, I think, a critical piece as well.
And go ahead, Michelle.
Oh yeah, I was just going to totally agree with that comment, and just even the piece before that about having to, and I think I made a comment when I was presenting, making sure that the U.S. is being balanced as a destination country, that we're not worsening shortages in other nations. That's a big piece of this. And so knowing where people are going, which you touched on, Lauren, in your presentation, is important, as well as, the licensure piece.
And
Right. That's
I'll
a
add
big issue.
that once people qualify, getting to the US can be a real challenge. It can be very expensive. Securing a visa can be challenging in and of itself. And often the wait times, visa retrogression can mean it can take years before someone is able to come to the US. And that's one of the reasons, although, I'm not sure to what extent it is a reason that we see a large percentage of the internationally educated nurses who do come and work in the US with professional experience in other countries beforehand. Many nurses take a mediated pathway to arrive in the US, traveling to someplace like Saudi Arabia or UAE, which have a policy of trying to recruit internationally educated nurses in order to expand the nursing workforce before coming to the US, or perhaps instead of coming to the US. And transnational mobility is challenging for so many different reasons. Even folks who are deeply experienced in their profession outside of the US context will find themselves using different kinds of equipment, or working in different types of interprofessional teams, or needing to learn new software. And so there can be a very significant period of adjustment, not to mention things like homesickness and culture shock. So
Right.
there is a serious hill to climb for internationally educated nurses arriving to work in the US.
Panels two, the panel coming right after this one today, and the next one's tomorrow. Panels 3 and 4 will be addressing a lot of that, and the connections between the different transitions from the different through the different stages that they have to go through, and how they can get support and all the help that they need. There were several questions about English proficiency requirements to work as a nurse here. I don't know if you want to address any of those. I can have a short answer for that one, but do you want to comment on any of the information related to English requirements related to licensure, patient safety, workforce access? And today, I don't know if everybody knows, but the HRSA, Human Resources and Services Administration, just announced the new minimum English proficiency requirements for healthcare professionals seeking an occupational visa. So their new website, the updated website lists those new requirements in terms of English proficiency, the exams that are being accepted, including the Michigan English test from Michigan Language Assessment, with the increased requirements that have been updated. Right today, I got a message a couple of hours before we started this webinar. But are there any references, anything you want to address in relation to English proficiency and the importance for licensure and meeting those requirements and patient safety?
I would just add that to the list that Lauren enumerated. U.S. regulatory bodies oftentimes have those requirements and standards, and that's on top of work visa requirements. And so I think to ensure just through a regulatory lens, where public protection and patient safety are paramount, I think those are additional hurdles associated with migrating to and working in the United States workforce. So I think it is just one of those things where, to Lauren's point, there's just so many hurdles. But it's part of the process, I think, for entry into the U.S.
Sure. Anybody else? I had a question, Lauren, to follow up on your comments about ethical recruitment. Can you elaborate a little in terms of how that can contribute to a better, kind of stronger workforce and sustaining all the recruitment efforts to contribute to the U.S. workforce, but also addressing the needs in the origin countries?
Yeah, I think that, as I mentioned earlier, the code is based on a larger labor code for safe and ethical business practices. This is really about ensuring safety and a quality of life reassurance for individuals. So it's a floor. It's a minimum that we should expect. And being able to work with recruiters to guarantee that they'll pursue these policies, that they'll address these minimum requirements, means that folks who are coming from any number of places around the world are able to feel safer and more secure in the recruitment process. You know, it's a mystery in many ways to travel somewhere else for a job sight unseen. And so the process of recruitment and hiring can be opaque to many people. So
Mhm.
when the recruiters participate in this program and adhere to these policies, we see greater satisfaction and security on the part of the workforce. Folks reporting that they're more comfortable and that they are confident in their process. You know, there was a survey, I believe, last year that found that health professionals that were engaged with current or prospective Alliance certified ethical recruiters indicated a very positive experience 90% of the time, and that 97 received a copy of their contract with plenty of time to review it and were ensured that they could understand it, and an overwhelming proportion didn't feel pressured to sign it. And you can imagine that the other side of that coin, feeling pressured to sign a contract that you haven't seen or haven't had enough time to see, or didn't feel comfortable in communication with their recruiter. But we're often talking about folks who are moving for economic security or for personal reasons that otherwise are really quite pressing, might feel as though they need to move forward despite their lack of communication, lack of transparency, and lack of opportunities for contract review. So ensuring that the practices of recruiters are aligned with that Alliance code can really create a better experience for health workers, which in turn can promote a much better set of experiences and outcomes for the health workforce more broadly, for patients, and of course for the communities that these health workers belong to.
Great, thank you. So we're almost at time. I'd like to close by asking each of our panelists for one final brief reflection. In about 30 seconds, can you share what is the most important trend that you would like to watch, to expect us to be watching in global nurse mobility in the US workforce? And what is one actionable planning or policy step that you would recommend? Dr. Washko, can we begin with you?
Sure. I think I would focus again on two things. One thing that Brendan brought up, which is the passage rates for the NCLEX. And in terms of a concrete policy action, I'd have to go back on sort of domestic policy, and I focus on data because that's what I do. The ability to count, to track, to know where nurses are practicing is so important to know the impacts of migration policies. We just don't have a uniform system in the US. So if I could change any policy, it would really be around that.
Great. Dr. Martin?
So I don't know if you'll be able to tell that Michelle and our team kind of track similar types of data here, the intersections. You know, I would go to something that she said in her presentation too. We similarly tracked very consistently over the past couple cycles of our National Nursing Workforce Survey elevated intent to leave and projected retirements. So I think that that's a metric to really keep our eye on. If that comes to pass at the levels that we're seeing, I think it would be a dramatic shift in terms of supply and work and healthcare availability. And then in terms of policy, I would also echo something that Michelle mentioned earlier. And I think oftentimes people shift their focus a little too much and a little too quickly to recruitment solely and uniquely as the strategy. I think policy solutions to ensure that we are retaining those who are qualified to practice and provide high quality and safe care is absolutely critical. Oftentimes, those are the more experienced workforce too. And I think we are seeing too much of an onus being placed on younger, more experienced nurses entering the workforce, being put in high stress, high acuity situations too early with too less experience. And so I think that is really the two things that I would say. A real focus on retention just as much as recruitment.
I
Perfect. Thank
couldn't
you.
agree more. I think data around where and how workforce members are practicing and also their preparation and prior experiences are absolutely critical. And I'd also like to see more opportunities to explore that data around the impacts of the current trends in global geopolitics, the ways that those flows of migrating nurses are shifting around the world in response to them. And for one policy shift, I'm going to come back to Brendan's comment about the licensure compact. I think that promoting mobility around the US in the context of that data collection and sharing is really valuable for the workforce and for us understanding how how workforce needs can be met.
Perfect. Well, thank you so much, Dr. Washko, Dr. Martin, Dr. Herkes. Thank you for sharing your expertise and helping us begin this symposium with a strong foundation in trends, data, and policy implications. And thanks to our global audience. We have participants from more than 45 countries, and this conversation reflects the reality that nurse mobility is not just a U.S. workforce issue, it's a global workforce issue, involving health equity and policy issues as well. The recording of the symposium will be sent to registered participants after the event. So if you couldn't attend, we'll be sharing this information with everybody else. And we hope this discussion provides a helpful foundation for the following panels. Without any delays, I'm now turning things over to Sharon Harvey, Michigan Language Assessment CEO, to begin with panel 2. Thank you very much and good evening.
Thank you.
Thank you very much. Hello, welcome to today's symposium on global solutions to the US nursing shortage, policy, recruitment and collaboration. Welcome specifically to panel 2, which is on building a sustainable nursing workforce, aligning immigration, workforce policy and patient care needs. So in the first session today, we had a very strong foundation looking at the bigger picture around the US nursing shortage. In panel 2, we're really going to focus on the role of internationally trained nurses, and we're going to answer a number of questions connected to this. So in a moment, we're going to meet our panelists. Panel 2 includes 4 rounds of questions, and these 4 broad topic areas were designed based on the questions that were submitted at registration by those of you who are taking part in the audience today. So thank you very much for sharing your thoughts. If you'd like to submit any additional questions, please do so in the Q&A function. You're able to do that. Please keep them brief, and we'll address as many as we can at the end of the session, although we don't promise to be able to cover them all. And then the symposium recording will be sent to all registered participants at the end of the session. So without further ado, I'd like to introduce our panelists today, and I'm going to ask the panelists to introduce themselves in the order in which they appear on the screen. So let's start first with Patty.
Hello, everyone. I'm Patty Artley. I'm the Chief Clinical Officer for Medical Solutions Group and the President of Worldwide Health Solutions.
Thank you, Patty. Rodrigo.
Hello, everyone. Good evening, or good morning, or good afternoon, depending on where you are. My name is Rodrigo Vaya. I'm an international educated lawyer, and I'm the Chief Global Affairs Officer at TrueMerit. And in that capacity, I'm also the Director for the Alliance on Ethical International Recruitment Practices that Lauren was talking about in panel 1. So if there are any questions on that, I'd be happy to answer those as well.
Thank you. Laurie?
Hi, I'm Lori Scheit. I'm Executive Director of the Missouri State Board of Nursing, right in the middle of the United States. where we license about 160,000 nurses and have a population of about 6.2 million. And I'm delighted to be here.
Thank you very much. Pleasure to have you as well. Amber.
I guess I'll go ahead first and next. My name is Mukul Bakshi. I'm the Chief Legal and Compliance Officer of the Evaluation Company, a credential evaluation company in New York City. I'm a lawyer by training, and before joining TEC last year, I was a CGF and S True Merit for the prior 11 years. Nice to see you. Thanks.
Thank you very much. And do we have Amber there? Well, let me go ahead and introduce myself. My name's Sharon Harvey. I'm Chief Executive Officer of Michigan Language Assessment. Michigan Language Assessment is a 501c3 not-for-profit organization that provides English language evaluation for people whose first language isn't English. We're jointly owned by the University of Cambridge in the UK through Cambridge University Press and Assessment and the University of Michigan here in the USA, and we're headquartered in Ann Arbor, Michigan. One of our exams, the Michigan English Test, or MET, is one of a small number of assessments that is recognized by HRSA in the USA as proof that an internationally educated healthcare worker has the required English proficiency levels to apply to work in the USA. And it's within that context that Michigan Language Assessment is hosting today's event. So it's a great pleasure to be here, and thank you to our panelists. We have some absolute industry giants here on panel too, and we look forward to hearing their knowledge and views during this session. So as I mentioned, there's 4 broad rounds of topics, so let's go on to the first one. The first one is something that I think is going to be something close to the hearts of many of the people out in our audience tonight, and that's the time it takes for overseas trained nurses to actually be able to come to the USA. So throughout the long process that includes recruitment, visa onboarding, credentialing evaluation, licensure and onboarding, up to the first independent shift, what aspects can be improved to speed up the immigration, credentialing, licensure and onboarding process? And what is the most realistic way to shorten that timeline within the next 12 months? Rodrigo, perhaps you can start with that.
Of course, my pleasure. I think one thing that's not controversial because it's not political, I think, is the use of digital tools. For example, True Merit is launching digital verifiable credentials for internationally educated nurses. I think that there are digital efficiencies in the process that we can use. For example, we're also working with nursing schools around the world to make the transfer of documents to verify education and licensure much easier, much quicker. So we also improved our turnaround times. But these are things that are not political, right? Because one of the major hurdles in terms of time is the immigration process. And for example, with retrogression, many nurses have to wait years before their number comes up, right? And so I can go into that, but let me start with just the short comment on the digital tools, and then I can elaborate more on the immigration if you'd like. You are muted, Sharon.
Mukul, what are your thoughts on this?
Great. And I agree with thanks, Sharon. I agree with everything Rodrigo said. I think there's a lot of room on the digital side. I'll kind of touch on some of the immigration pieces as was discussed in the last session and this session. Obviously, visa retrogression, which are these lines for permanent green card visas. That's a continual issue. You're talking about a kind of a couple year wait. That's the longest lag in the process. But there's a couple other things to note. One is some of the recruitment firms on this call have been advocating for the reestablishment of a nurse-specific visa through the Health Workforce Resilience Act that would obviously help create more visas in that space. In the last couple of years, many nurses have been going to nonprofit hospitals through the H-1B pathway. That was relatively new, but the Trump administration's $100,000 fee for those visas has obviously been an issue for some of that. So, I think that's obviously the biggest piece here. Credential evaluation services like True Merits or TECs can be more efficient and quicker. I would say there's mutual recognition of credentials across borders, particularly within states with the compact or looking at other countries could also help speed up that process. Onboarding is really key as well. The issue there, I would say, is that often when we're talking to people, there's a drive to make onboarding processes longer and deeper to ensure that a nurse is successful when they get to the hospital floor or to the nursing home floor. And so there's some kind of, I guess, tension between do we want to get people fully independent on their shifts as soon as possible, or do we want to make sure they have the support to be successful in the long term? And so I think thinking through that is challenging. There was some discussion at the end of the last call on the new English scores that HRSA has just adopted for the Section 343 health worker certificate, which you need for a occupational visa as a nurse or PT or anything else. That's something, I know a lot of the people on this call have talked about and worked on for several years. I think again, there's tension, right? So English has historically been a barrier for many people to get through the whole process, but it's really important for the public safety aspect of being a nurse, and also for ensuring that the nurse is able to be successful in their careers. And so, that change, while I think is a very welcome one, will also have potentially some delays for certain nurses through that process. So the last thing I would add is kind of the real key here is support throughout the process. That includes through recruitment firms, through kind of established mentorships into hospitals, but also through informal networks. I know a lot of there's nurse representative organizations like the PNAA. There are Facebook groups that are more informal, and those are all ways to help people kind of navigate this process in at least a more well-supported way, if not a more efficient way.
Thank you very much. Thank you. Laurie, what are your thoughts from as a representative of the state boards of nursing?
Yeah, so we license nurses, of course, and even though they're in the middle of the state, or in the middle of the United States, we've seen an increase in the number of international applicants. And so my kind of best advice for that is to start early. All state boards of nursing, no matter what state you go to, have a website that will list their criteria that you need to meet to get a license. So pay attention to that, apply early. I mean, that's the best advice, and get your documents in early. Start your credentials evaluation process early as you can is better. With the only caveat being that talking about the English proficiency exams, most of them are only able to verify the exam if you took it within the last 2 years. So if you have to take that, you have to be conscious of that, because we will want to primary source verify your English language proficiency exam. And if they won't, verify that post 2 years, that could be a hurdle. And I think the majority of states now have portals where you apply for a license online. We're certainly one of those, where you can track when your documents have been received and just follow your checklist of what you need to do. Email the board if you have questions. Make sure you have a good email address where you can be contacted should the board have any questions. And I think that's one issue we have seen with recruitment firms. Sometimes the recruiting firm wants to sort of be the gatekeeper or the email address for that contact person. And for us, we want the information of that person who's applying. They own that record. That is their license that they will obtain, and it doesn't belong to the recruiting firm. So we do have some issues with that sometimes, that we want to be in contact with you. You certainly lean on them for advice and help in getting your application done, but it is ultimately your license. And once you obtain it, then that email is what we use to communicate license renewal and other things that you need to know. I think the other thing that you touched on a little bit was about the credentials evaluation. And so Missouri, they go up to 40 states now, are in the Nurse Licensure Compact, and most people want to try to obtain a multi-state license, so it gives them that mobility. And it does require that a credentials evaluation be completed. So there aren't any states that are in the compact that would allow you to just directly submit transcripts.
Thank you. So quite a complicated picture, and but you're putting quite a lot of responsibility onto the individual nurse themselves that's applying and saying
Yes.
they should absolutely own the process, apply early, and make sure all communication that they manage the communication.
Yes.
Thank you. Just a follow-up question for everyone on the panel. Is there anything that policy matters aside, and I know we could discuss policy matters probably for the duration of this session, but policy matters aside, is there anything that any of you think is easily fixable or addressable within the next 12 months that could help speed up this overall process?
Well, I think some of the states, when you think some of the smaller states allow the nurses to complete and start the process earlier. So they allow them before they even get here to start the pre-license process. If all states did that, we'd be a lot easier and a lot faster. So I think that would start and shorten the timeline.
Thank you, Patty. And is there anything else you would like to add from the point of view? Obviously, you come from a major healthcare recruiter. Is there anything else that you would like to add as your thoughts or advice for individuals?
Well, nothing that hasn't been already added with my colleagues.
Okay, thank you very much. Okay, then, so let's move on to the second round, which looks then it was an element that Dr. Herkes from True Merit touched on in panel 1, which was about ethical recruitment and also a little bit about harmonizing, which Patty, you've just mentioned yourself. So the themes are definitely all connecting across the symposium so far. So how can the US modernize and streamline immigration pathways for internationally educated nurses to remain competitive globally while ensuring ethical recruitment and protecting source countries' workforce needs? Patty, perhaps you can start off with that one, please.
Well, similar to what I just talked about, when you think about the way that we're doing the Nurse Compact, when you think about how we can really standardize processes, and if we could come to a common ground on what we would require, that would allow us to really make things a lot easier for us. And it would allow us to really help them as nurses process a lot quicker.
Thank you. Rodrigo, what are your thoughts on this?
Yes, so let me start by saying that I think it's important that we better recognize what the problem is, because sometimes we talk about shortages of healthcare professionals and maldistribution, and we seem to be a little bit far away from the actual problem, which is the healthcare delivery to patients. Because shortages is not just about numbers, like a stock unit in a supermarket. Oh, I don't have enough pineapples. Well, so bad, just buy some other fruit. This is about patients that have to drive longer distances, surgeries that are postponed, clinics that have to close. And until we recognize that this is a huge public health problem, things won't move as fast as we would like. So I think that's a very important first step. And as someone was saying in the first panel, international recruitment is not the silver bullet. It's not the only solution. Recruitment cannot be the only focus. But the fact is that education and retention measures are more long-term measures, right? Even if you start today, which we're not, if you start investing today on those, you only reap the benefits from 4, 5, 6, 10 years from now. But now there's already a problem. And for the now, we need much bigger numbers than what we have. HRSA said there's a shortage of 300,000+ nurses, right? But we only had the visa screen applicants of 20,000 last year. So how are we addressing that shortage that exists today? So one thing is more visas, more. And there are already, for example, 40,000 visas that have been approved by Congress and were not used. And there is bipartisan initiatives to reuse those visas, for example, or to create an immigration system that's specific for healthcare providers, because it's a shortage situation that has very dire consequences for our society. And so it shouldn't be mixed with other issues and other arguments. So create a specific immigration pathway that addresses those shortages concretely. I think that's a very important thing. And do it in a bipartisan way. It's possible. There are initiatives in Congress. Just be courageous enough to take them to the end. On the ethical recruitment side, I would like to say, as the director of the Alliance, I think it's important not to reinvent the wheel. We have an alliance that has certified ethical recruiters. We cover already the vast majority of international recruitment into the United States. What we need now is to build on that and make sure that ethical recruitment is the market standard, that it's not a market exception or a market niche. It is the standard, and you should be able to comply with ethical certification requirements. And so along with the development of this domestic market in the US, we're also looking to expand this international recruitment certification internationally. And I think that will be important as well as other countries look, not only from a receiving country, where you say the people that recruit for us, the companies that recruit for us must do it ethically. That's one perspective from a receiving country, but also from the sending countries, where they should say the people, the companies that are coming in to recruit our nurses have to do it in an ethical way. And they should have those standards in the sending countries to make sure that companies from wherever they come from are not recruiting their national healthcare professionals in an unethical way. So I'll stop there. I can elaborate more on those issues if you'd like.
Thank you. Yes, I'm wondering what outreach support we do back towards the sending countries to help them establish those policies and guidelines for the domestic situation.
That's a very important question, and True Merit is also discussing with international organizations and other governments about how to give back, right? Or how to invest in the source countries that ultimately will guarantee also the sustainability of the receiving countries, right? Because this cannot go on, as Lauren was showing. High-income countries cannot continue to drain the low-income countries out of their healthcare professionals without giving anything back, because at some point that's going to stop, right? Either because they would not allow it, or because there are no more resources there to explore. So we really have to think sustainably, and how this could be a virtuous circle instead of a vicious circle. And we're discussing with other governments and international organizations, not only to build better bilateral agreements where both parties have balanced and reciprocal advantages of having these agreements to develop the health workforce, but also multilateral agreements that look at regions instead of just government to government provisions, because those cannot capture the complexity of international recruitment. For example, in areas like Africa, it's not enough that country X does an agreement with country Y. You have to have an approach that's regional and that takes into account several high-income countries and their demands, because otherwise what you have is a competition between those high-income countries that will drive down the level of recruitment practices, and we cannot have that. So
there was actually a related question that came in the first panel about the Ethical Recruitment Alliance and whether you certify recruiters outside the USA or just within the USA. Are you able to answer that for us?
Well, I didn't see exactly that question, but I can answer that one. At the moment, no, we only certify recruiters in the United States, but we are looking to expand this internationally. And we are, I can say at this moment, looking at an application coming from the first country outside the United States. And we plan to expand that to other countries.
So watch this space is what you're saying.
Yes.
Okay, thank you very much. Thanks, Rodrigo, for the very complete answer. McCall, any thoughts on this, on the ethical recruitment question?
Yeah, it's a tough question, one I've thought about for a long time. I think Rodrigo covered a lot of the bases, but I'll probably like zoom out a little bit to kind of the high level issue, which is that, what is ethical recruitment? And I kind of think of it in two frames. There's the micro ethical recruitment, which is the individual nurse. How is he or she treated by their recruiter? Are they fully knowledgeable of what their contract provisions are? Do they have grievance procedures? It's really about that individual nurse's experience and whether they have the support that they need, whether they have fair contracts, et cetera. Then there's the macro issue, which is, I think there's some tension sometimes. The macro issue is how do we ensure that ethical recruitment is not negatively impacting source countries, right? And there's some tension there, right? One of the things the World Health Organization has done, it has been establishing red list countries, and ethical recruiters generally avoid actively recruiting in those red list countries. That seems very reasonable. You don't want to further deplete those countries, but it gets really complicated really quickly, right? Because an individual nurse should be able to make the right decisions for themselves and their families. So do you say they can't leave their country, even though a country is willing to have them because it takes away from another country's workforce? I mean, that's a question that has to be grappled with. And I tend to try to err on the side of supporting the individual's right to make their own self-determination. So that's one piece of it. And then even if you do that, active recruitment, right? So the way a lot of recruiters have gone through this question is they won't actively recruit, but if a nurse is able to reach out to them, they'll be able to hire that nurse because that seems, less messy. But there, are you just allowing people who have kind of informal networks or are able to reach out on their own to get access to opportunities that those who don't have those networks won't have the opportunity to do? So there's just a lot of complications there that I think are really, hard to grapple with, and there are no easy answers. When we're talking about those nurses in general, right? Often when we talk about the shortages, they're based on the number of nurses or doctors per 100,000 population, right? So if you have a small number of nurses working, then you're a country with a chronic work shortage. That makes sense. But the problem is a lot of these countries could use more workers, but they don't have the resources to actually hire those workers at a fair wage. Right. And so you have countries that really desperately need workers, but actually have people who are well qualified and are unemployed. Right. So how do you handle the situations? I think part of it is potentially kind of what Rodrigo is alluding to, which is like win-win solutions, where you're able to have investments in workforces in sending countries that allow for some of those workers to go abroad and have other opportunities, and some of those to stay and be trained with support of recruiters or other governments, et cetera. But the whole, I think, larger point is that it's a real challenge to grapple with a lot of these issues. Ethical recruitment is a really important principle, but what it actually means on the ground, how do you parse different ways of doing it, it becomes much more difficult. And I think that's something that requires a lot of grappling. And there's a lot of kind of more simplistic oversight on this stuff. I would also say on the kind of the policy angle, I mean, yes, there's a lot we could do for immigration policy in the US. Um, I think one of the things to consider, of course, is while I support, the number of IENs who want to come in and having them opportunities, certainly in other countries that have had a larger share of their workforces be IENs, that can have impacts on worker benefits or worker wages. And there's some labor implications with immigration that also have to be considered, particularly in countries that have, you know, 10, 20, 30, or 80% of their workforce being foreign educated. And the rules around visas often mean that those workers have fewer rights and less opportunities to move between jobs if there are issues.
Thank you. Yeah, very complex issue. I'd like to go on to a related point, which touches on something that was raised in round one, and this will be for you, Laurie, thinking about the states. States vary widely in credential evaluation, English requirements, and licensure processes. What would safe harmonization look like, and what can realistically be standardized without erasing important state authority?
Yeah, so an interesting question. So I think most of you know that in the States, we have nurses, which is Dr. Brendan Martin spoke earlier tonight from National Council of State Boards of Nursing. So we have nurses, and so every nurse has an NCSB and ID number. So that's their unique ID number that they is assigned to them when they first register for the NCLEX exam. And then that ties your records together in nurses, no matter where you have a license. So in that system, and that for domestic or U.S. licensure, only boards of nursing and NCLEX data gets in that nurses database. So it's primary source verification. Boards of nursing contribute the education data. So for someone who's educated in the United States, you have where they went to school, the degree type, the graduation date, so forth. In a perfect world, right? You know where I'm going. If we had something similar for international, wouldn't that be grand? Because what we know, so why, so I'm going to talk, public protection and fraud risk. So in, our, role, I mean, I think probably everybody on this call understands what it is, but it is to protect the public, to make sure that, because we know this is a profession, right, that can cause great harm and to someone that's not properly educated and licensed. And it also maintains the trust in the healthcare system and nurses when they're properly credentialed. So if you have a closed system, so to speak, is kind of what I'm talking about, because the data going in is only coming primary source verified from a board of nursing and from NCLEX data. If we have an international system, I understand that has lots of implications because you're talking about laws. A lot of things come into that, but a digital wallet, if you will, that would be helpful, because what I tell people is, I think one of the frustrations probably that people sometimes have with our state is we say that if you've had a credential evaluation and it's over a year old, we want another one. Part of why we do that is because there isn't a way for me to know that that person could have had discipline or something happened to that license in another country, right? In nurses, there is. If I check under a license today, and I check it tomorrow, if that license has been disciplined, I know that. I don't know that if a credential evaluation is old, right, and been sort of passed around. So that's one of the reasons that we do that. So if you had a way that primary source information is going into a, and I don't know True Merit, I think you all are working on something like that. Now, the education criteria piece, I'll address a little bit, because I think that's an issue even domestically, if you don't know that it is. But I think some states like ours, we're pretty easy, I think, as far as like education saying that you have to have graduated from an approved program. And for domestic, that's approved by a state board of nursing. There are, however, some states that say things in their nursing program criteria that, all of us say you have to have, education and, the major categories, right? Med surg, peds, OB, so forth, so on and so forth. But some go farther and say you must also have specific clinical hours in certain content areas. And that's where there's a disconnect even domestically. And so we see that even in our domestic licensure scheme. In fact, I had one just this week that they were questioning a program that the Missouri board approved because they did not see on the transcript there were clinical hours in certain content areas. So that is an issue that exists outside of the international scheme. So I'm not sure if everybody's aware of that. That is true today. So I think that the movement toward harmonizing that will help on the international front as well. But I do think it is complex. We have different accrediting bodies as well. So not all nursing accrediting bodies that accredit nursing programs are on the same page. There's definitely opportunity to improve that, right? That's what I would say, and I'm for that. I think that the compact, again, I keep stressing that, but it's because it's come a long way that it's, and I think that's how states are starting to address it is you could have someone that is practicing your state on a compact license that says, has a compact, a multi-state license from another state, and they might not necessarily have met your specific criteria, right? So that's one way people need to look at that. So, I mean, I don't have the answers. I think that we are moving in that direction. I've seen movement, but that would be my solution.
Thank you. There's some great thoughts there. I actually wanted to
Yeah.
go back for an audience question that came in a little while ago that perhaps you can broadly answer. And the point was made that if somebody's fully trained in their own country, why do they need to take NCLEX in the first place? Why is there this need for an additional qualification? Is that something you can answer? I can also ask the other people
Uh,
to come in.
Sure, I can, and then others can chime in. But I
Sure.
think Dr. Brendan Martin, again, I think earlier I kind of alluded to it a little bit, but the licensure that you obtain in the States is for you to practice safe and effectively at entry level in the United States. And that's it derives from a job analysis where you are seeing what it takes basically to practice safely and effectively, and that becomes the blueprint for the test plan. So so that is the criteria, that is the benchmark. In addition, it's two parts. You have to have the education, and then you have to pass the licensure exam to show that you're competent entry level practice based on a job analysis is where that derives from.
Thank you. Thank you. Would anybody else want to come in on why people need to take another qualification when they're already fully qualified in their home country?
If I may, Sharon.
Yes, please.
So I think what Laurie said is correct. Each country has its own regulation. It's a regulated profession, nursing, right? So you need to make sure that professionals are not just that they have the qualifications, but that they are ready to practice, right? Or not just that they have the credentials, but that they have the qualifications, the competency as well, right? That's the purpose of an exam. However, what TruMerit has been thinking is, can we look at a global standard for nursing? And we developed the Certified Global Nursing Program, where we have a global standard that looks at 37 different frameworks from all regions of the world. We gathered more than 70 experts from more than 50 countries, and we developed this standard. And although this standard is not used by a regulatory agency as a test for their own jurisdiction, what we think is that this could be eventually a global standard that's accepted as the basis for not having to repeat, especially if you're like Lauren was saying, if you're doing several steps of migration, you're going to Saudi Arabia, then you're going to Spain, and then you're going to the US, that you have to repeat every time the same thing, but rather if along with these global standards, you could have uh, adapted national standards that would kind of bridge that global standard. That's a question, right? I'm not saying this is the solution, but it's a question. In any case, we do have the certified global nurse program that shows the adherence to this qualification. It's a career development tool, let's say, for nurses, open to any nurses. It's offered all around the world, but we're hoping that we can create a debate on this because I think that's a very important thing. And if you look at other areas of the world, for example, the European Union, where you have a single market, but you have 27 different countries with different jurisdictions, and you have very complicated ways to recognize or mutually recognize qualifications among professionals with different languages, different school systems, different levels of education. If you can create that basic standard, that's the essential standard, and then eventually complement that for accounting for specific jurisdictions, I think it would be a great step forward, not necessarily in the US, but in other parts of the world for sure.
Thank you. I was going to say it's quite an interesting one, thinking about the US and the different standards across the US before we talk about international standards. So, but that would take us in another direction. So I'm going to move us on to round number 3, which is when we start to look really at the human side, let's say, of international nurse mobility. What are the most effective models for integrating internationally trained nurses into US healthcare systems, from credentialing to transition to practice? And how can employers balance speed of hiring with quality and cultural readiness so internationally educated nurses aren't placed at undue risk or in unfair arrangements? And perhaps Patty, you can start that one for us, please.
Sure. So I'm going to probably not just answer this from my role and the organization that I work in today at Worldwide, but also my prior role, I was the chief nurse of a large health system. And I think the most important part is that you have to start early. From the moment you make those offers of the clinician, you have to start preparing not only for the team that you're receiving the individual, but also preparing the nurse. For us, we have clinical modules that we have to prepare the nurse. We have skills assessments, English prep courses, so that the clinicians make a smooth transition. We work with the organizations to make sure that they are well prepared and identify what they need. But I think it's really important. What we did was we developed a playbook that really identified different types of practice by nationality so that organizations understand what's needed and what kind of practice those nurses are accustomed to and what they can then model their orientation after, because it's really important that they understand that sometimes the practice is very different and that they have an appreciation for it and that they align the resources appropriately to make sure that they're well supported, because that onboarding is so critical to their success and the high quality that they're going to get. And I think it's so important when you think about the clinical support. That's really important for the high quality, but it's also about the acclimation to the community and making sure that they have an outlet and making sure that they're supported emotionally and making sure that they have a safe space and a contact that can help them navigate because we talk about how they could be taken advantage of, and that won't just happen in the healthcare system, but that can happen outside of the healthcare system as well. And so making sure that they know that they have a network that can be established. One of the things that we used to do was setting up a network with phone numbers and email contacts of international team members who that they could create that contact and colleagues that were aligned with. So it's so important that we're thinking about from the time the offer's made that they begin preparing their team and we're preparing the nurse to make sure that they're welcomed and ready to join the team.
Thank you. That's all good advice and something that I can identify with, having changed countries for a job myself. McCall, what are your thoughts on this?
Yeah, no, it's a great question. I second everything Patty was talking about. It really comes down to support, providing support throughout the process for that nurse. So yeah, obviously good training. The fact that there are all these modules online now makes it much easier to provide at least that clinical support. Mentorship programs, both informal and formal, are really important to ensure that integration. And as Patty was talking about, it's both really from a cultural side as well as the clinical side. On the other side, grievance procedures. So this is something that's really important. And you talk about when you're in the HR side, but less so in this kind of recruitment side, which is giving people the ability to raise concerns early. I can't tell you how many recruitment firms I've talked to and talked to people who are like, we could have fixed this problem if we just knew about it. And how many hospitals, right? So providing ways for people to raise up when there are issues, because often things could be just a miscommunication or it could be change. A nurse who leaves a contract early because they just didn't like their assignment, right? Maybe that could have been dealt with either within that facility or by finding them another role that's more appropriate. So just being able to fix those issues early. Of course, training is really important here, and it's really for internationally educated nurses, but also when you have facilities where there are lots of IENs coming, making sure there's support for the domestic nurses there too, because often there's an additional burden placed on them in terms of making sure that those people are trained appropriately, and that should be recognized. I think a best practice that's used by a lot of recruitment firms and facilities is longer term assignments for nurses who are recently there. Obviously, within the model, there's kind of shorter term models like travel nursing for domestic nurses, which can be very useful in filling gaps. But when you're first getting an assignment in a new place, being able to really develop community and both within the facility you're working and in your general kind of day-to-day life, that can be really helpful. So I think there's a lot that can be done, but it really comes down to support. And what's interesting about a lot of this is, you know, everything costs money, and there's a lot of things, the solutions that are really expensive. A lot of these solutions are actually relatively cheap and maybe even cost effective. So,
Thank you very much. Thanks for your thoughts. Would either of the other panelists like to add anything on this topic? There was a follow-up question actually and it was something that also came up for me in a professional conversation earlier today. What would you say are the most viable and safest visa or employment pathways for internationally educated nurses applying to work in the US, say today? There's a lot of companies out there, who are advertising services and a lot of nurses who are looking to come to the US. How can they do that safely? And McCall, you're on screen for me, so I think you're probably pretty
cool.
qualified to answer this. Sorry, I'm
Perfect.
picking
Yeah,
on you.
that sounds great. No, I think this is the challenge for any nurse in the process is how to make these really big decisions, right? I know there are many of these people who are watching this webinar right now. I would say a few things. I mean, do your research early. I think it's a good way to start. It's come up a lot of context. Lori was mentioning it in the licensure context, in the earlier discussion as well. Like, I think it's like it's thinking about every stage as much as possible earlier on. So, like, what country do you want to go to? Do you understand what the benefits of each country are? What are you picking when you're going to a state? Do you want to go to California because it sounds sunny, even though you don't know what the licensure requirements are, right? So, doing that research and understanding those goals is really important. Obviously, I would suggest that nurses pick a firm that's certified by the Alliance or is in some way reputable. But I think more broadly, talk to people. There are a lot of informal groups on Facebook, as I mentioned before. There are groups like Sienna and groups like the Philippine nurses, the Indian nurses. There are lots of groups and communities where people can share their experience and help you understand what who are the good firms, who are the harder ones to work with. There's also a lot of kind of telling people too good to be true stories. Like, especially during the pandemic, I would say it was even more acute when a lot of people were entering the market. I'd hear them tell hospitals, hey, you can get a nurse here in 6 months or get 20 nurses, right? Making promises that couldn't be kept to the hospital. And similarly, making promises that couldn't be kept to the nurse, right? So the nurse was told we'll find an assignment for you anywhere. And then ultimately was moved somewhere else. So I think that relates to making sure that whatever you're being told aligns with what you're actually signing. And if you don't understand what you're signing, find a resource like a lawyer or somebody else who can help you understand what the actual commitment is. Because people might tell you something, but really it's about what your commitment is legally, and you want to make sure that kind of is in line with what your expectations are for that pathway.
Thank you. Patty, is there anything you'd like to add from a recruiter perspective on this, that advice that you would give to nurses applying to come here?
I was going to say the same thing that Nicole said, is that you want to start your research now. Like, if you're thinking about coming, start it now. And I think it's really important that you think about what's important to you. Because so many times we'll speak to individuals and they just randomly say, I want to go to New York City. Well, what about New York City? This is why you want to go to New York City. But it's just because that's what they know. So it's really understand what's important to you and where you really, what aligns with that. I hear people say snow's not a big issue, but it really is after year one. I hear a lot of people say that snow is an issue, just like, it's fine the first year, but it might not be the next year. So really thinking through what some of those things really mean when you're picking a place. But I think it's really important to find a recruiter that you trust. Interview different recruiters, interview different companies, talk to them, and speak to them. I think
that's good.
direct hire is important for me. I use that as a chief nurse, and I've used contract labor. So I've used them both, and I've chosen both of them as a CNO. So
can you perhaps explain that to the audience,
the
for people who aren't familiar with the terms? Yes.
Happy to. So there are two really basic rules of thumb. So a direct hire, you are hired by the hospital or the nursing home or the dialysis center. You're hired by that location, and you are hired as the staff member, and you start collecting their paycheck and the benefits and everything day one. The minute you start working, you're working for them. In a contract, you sign a contract with a company. So you sign the contract and you work in a facility, but your contract is with the agency. And you may work a 2-year contract or a 3-year contract. And at the end of that contract, the agent or the hospital hopes that you'll decide to stay with that hospital, but you have the opportunity to go anywhere after that contract is completed. Those are the biggest differences. And the difference with a direct hire and the agency is really around, the differences that you have are really in the agency one, you are completely tied to that contract. So your mobility, if you leave, you owe back the pay. And in the direct hire, if you do leave, you have a negotiation with your hospital.
Thank you for explaining that difference, and good advice to nurses applying, that they should interview the recruiters in the same way that the recruiters are interviewing them.
Sharon, can I add some thoughts on this? I think it's important to say that most nurses come on an employment-based immigrant visa, EB3, for permanent residence. Some come with H-1B visas, which is temporary. But I think all those pathways that are legal are safe in of themselves. What potential candidates have to bear in mind is, and be prepared for, is that it's going to be frustrating. It's going to take a long time. It's going to take a lot of paperwork. It's going to take money to do the whole process. You have to accept that. Do not cut corners. Don't try to cut corners in terms of immigration. Never try to come in illegally and think that then you can regularize your situation. Never try to, believe in stories of, oh, if you do this and that and you go there and whatever. Don't believe in those stories. There are the legal pathways, and those are the safe pathways. And it's going to be frustrating. It's going to take a long time. Myself, as an internationally educated professional, I came to the US as well. I'm now a US citizen. I went through all of that. I know what it takes, but it's the only way that's actually safe, and it's important to say that.
No, that's very good advice, Rodrigo. If there was one place that people could go to that kind of gives them the 10 steps to
Yes.
applying legally as a nurse in the USA, is there somewhere you would advise them to go for that
Well,
advice?
you can check our website. There is some information there, of course. We can also provide much information. But you reminded me of another important issue, which is we have to be better at providing that information in the countries of origin. I've been to several countries, and I've heard from nurses of several countries that say, oh, we don't know. We don't even know where to look, right? Or the information is not in my language, or I think that we all have some work to do to go more to the places where they are, and give that information in their own cultural context. I think that's also very useful.
Yeah, that's a good point, Rodrigo, and perhaps a takeaway for the organizations that are taking part in this symposium, that collectively we have a shared responsibility to make sure that people applying to come to the USA have access to up-to-date, accurate, and correct advice on the legal way of doing this. There was a question that came in from a member of the audience that relates to this subject. So we'll deal with that, and then we'll go on to the final panel. And it was thinking about the human aspects of coming into the country. How can hospitals better support international nurses during onboarding and orientation? We don't have any representatives from hospitals on the panels today, hospital systems, but any thoughts from anyone on the panel on how hospitals can better support international nurses?
Well, since I was part of a hospital system all my career, my entire career up until 3 years ago, I think it's so important that the hospitals work closely with whatever agency they're working with. And they develop together what kind of programs they need, because it's a shared responsibility. It's not one side or the other. It's a shared responsibility. And each one of them have ownership to make sure that not only the nurse is prepared, but that the units are prepared for the individual that's coming. I found that it was really important that we had welcome letters, that went out to the individual, that we had an all about me kind of poster that was on the unit, and that allowed our team a month before the individual came to the unit that we knew all about their favorite things. And we had the individual who was going to be precepting them introduced to that individual well before, they already made the connection. Sorry, my light keeps going, but I apologize. But it's really important that it is a shared responsibility, and that the two organizations create the plan for what is necessary for the nurses. We created cohorting. So when we hired large number of international nurses, we did cohorting when we were doing onboarding for nurses. And when we were bringing them in for clinical day, when we were looking at whether or not they knew the pumps or whether they knew policies and procedures, it allowed us to see where their clinical competence was, and we could tier them in 3 different tiers. And I think that was a really good assessment and allowed them to learn at their own pace. So it really did help onboard them in an appropriate way and in a way that they learned best. But I think that there are a lot of ways that hospitals can learn and prepare them if they work with their agency.
Thank you very much, and thanks for sharing that hospital perspective, Patty.
Yeah.
Well, let's go on to the 4th and final round. And that relates to patient care quality and continuity. So how does reliance on internationally educated nurses affect patient care quality and continuity? And how should this strategy be balanced with strengthening the domestic nursing workforce over the long term? And perhaps, Patty, if I could go to you to first answer this question, that would be great.
Sure. So as a senior nurse leader, you always have a workforce strategic plan. That includes short-term and long-term recruiting and retention strategies. This is obviously a long-term plan. We know it's taking about 30 months to 2 to 3 years to onboard an EB3 nurse. And when the pandemic hit, we know that a lot of seasoned nurses left the workforce, and we lost a lot of knowledge. What happened then, we backfilled those roles with newer nurses. Patient acuity continued to increase, and that caused an experience complexity gap. And the international nurse is coming with a lot of experience, and they have that critical thinking. They have a knowledge of the disease process, medication management, situational awareness that can't be, just absorbed with a new nurse. They're so novice. And so that complement to the team by having that seasoned nurse was so incredible for all of our units that when we hired our international nurses. And during that 2020, 21, 22, it was only a 12-month period of time to get an EB3 nurse, 12 to 14 months. So it was, it really helped really bridge that gap. But the international nurse really does add so much value by diversifying the workforce and helps the team grow to really, I think, appreciate how we care for our patients holistically. They serve as coaches and mentors and preceptors and charge nurses in a very short time because they've done that in their country. And they, when I look at my workforce, that we have in our pipeline, our average nurse has a 9.2 years of experience. And so when you think about adding that to your workforce, it has a very different complement than if I were to hire a brand new nurse. And most organizations are having a really hard time recruiting seasoned nurses. So this adds a resilient part of the workforce. And you know, these nurses have already developed or demonstrated resilience and adaptability because they've left what they know and they've already taken a leap and come here and adapted to an entire new culture, an entire new way of doing things. So they really do add a whole new dimension to the team. And I've worked with international nurses my entire career and have committed to hiring international nurses as a nurse leader because of what they add to the team. And they help us challenge the status quo.
Thank you. Thank you. Some really positive thoughts there. Rodrigo, any follow-up thoughts?
No, I mean, what I can add is I think following the same sentiment as Patty is internationally educated nurses and other professionals as well. You know, they bring different experiences and they bring different contributions that are very valuable, and they are a critical piece to address some of the biggest challenges that we have in our health systems, right? Mobility is a human right. It has to be safeguarded, but it's not just that. It's part of a solution of a much bigger problem. And it's internationally educated nurses should not be used as a pawn or an argument in favor or against other solutions like education and retention that are equally important. But I think I want to put the emphasis on equally important. We should give the same attention to internationally educated nurses migration as we do to education of domestic healthcare workers, as we do it to retention issues, because all of those will together will give the contribution that we need to address the challenges.
Thank you.
A more broader kind of conclusion statement, let's say.
Thank you, Dan. Very, very good points.
Can
Laurie,
I jump in for a
McCall.
second? Oh,
Yeah,
sorry.
yeah, McCall, please do.
So one thing I want to add here is, you know, we're talking about internationally educated nurses as the migrating nurse, and I think that's obviously very key. What's been interesting over the last few years is the role of internationally educated nurses who don't migrate, right? So, you know, I'm thinking of virtual nursing. So in some hospitals, there are nurses in Manila who are monitoring a nurse in a hospital or nursing home in, say, South Carolina. And then that allows you to have fewer nurses on the floor and there's somebody still watching them, right? Or insurance companies are using outsourced, you know, licensed healthcare professionals abroad as well to do some of that work. There's certainly benefits from a cost perspective. It's a broader policy question of whether that's a net good or bad for a state. People like Lori and executive directors in other states have a lot to grapple with when they're thinking about people, nurses providing border care to people in their state who might be in another state or another country. But I think that's interesting because it allows us to, you know, we were talking about in the prior panel this maldistribution of nurses. And as we have more technological tools that allow a nurse to be in one place and a patient to be another, there are both opportunities to help address those issues, but also a lot of regulatory and other concerns on how to do that effectively while ensuring that patients are protected.
Thank you. Thanks for your thoughts. Anything else on this topic before we wrap this one up. Let's then move on to final thoughts from the panelists. Any final comments and recommendations thinking about this before we move on to any final questions from the audience? Any thoughts from the panel about any of the topics that we've discussed in this session?
Well, can I
Please.
another thought? I really want to give a message to internationally educated nurses that are listening to this, which is, and maybe I don't know if there are some outside the United States or in the United States that are thinking about migrating. Don't give up on your dreams. I want to say, it's a difficult journey. You'll encounter many obstacles. It's not easy, but many make it, right? And they complete the journey and get to what they want to do. So don't give up. True Merit and other organizations are here to support you. The recruiters, certified ethical recruiters, are here to support you. And so just want to finish with that message.
Thank you very much, Rodrigo. That's a very nice sentiment to end on.
Well, I'd like to piggyback on that. We did see one of the questions that was asked earlier was, what do I have to do, or what advice would you give for someone who's on that journey? And I would highly recommend that you stay clinically competent. So we see a lot of individuals who go to the BPOs or have gone to other areas. They've gone to the virtual space, or they've gone to other organizations where they've left the bedside. And when we're presenting candidates to clients, they're very interested in those that are clinically competent and that are clinically sound. And so I would strongly recommend that if you have that desire, and this is part of your journey, I would definitely stay clinically competent and stay at the bedside right now as you're continuing on your journey.
I think that's great advice, Patty. We've been working on a project in Mexico, and that same feedback is coming very loud and clear from employers in the USA that you need to get really good quality experience. But if you get your language proficiency and you get your NCLEX and you have really good experience, then it may take a bit of time, but there, as Rodrigo's just said, there are opportunities here for you. And the better your experience, the better your chance of fulfilling that dream. Let's have a look and see if there are any other questions. I know there are some particular things that have come in here. Anything related to the MET exam, we can follow up with you after the webinar. We'll put up our contact details at the end, and we're happy to support you and to get you through the MET. And I know, Rodrigo, you've been answering questions in the background related to a host of areas, including the some legal aspects. There was a question about people who are preparing within the USA, and what advice would we give to internationally educated nurses preparing for the NCLEX and licensure process already in the USA? And that's an interesting one. I think we're seeing quite an uptick of nurses applying who are already based here. Is there any difference in the process? Is there anything they should be aware of?
Well, if they're already here, I mean, they'll, it's the same process, but I wonder if some of these questions had a theme about preparing for the NCLEX, or people reporting they were having trouble passing the NCLEX and what to do about that. And my kind of advice about that is, or where to work, like see if you can get a job as it varies by state what certifications or registrations you need is probably a better word. In Missouri, it's a certified nurse aide or certified med tech. But see if you can get that level so that you stay, kind of to Patty's point, at the bedside and gaining some experience and learning from other nurses. And we've had some success with those that are not successful on the NCLEX exam of getting their foot in the door in a hospital or an employer in that role, or a nurse tech that doesn't require certification at all, where you're doing some patient care, but not at the nurse level. You know, you're not doing nursing assessments and such, but you're doing some hands-on patient care. And see if they will sponsor you to help you possibly, pay for a review course. So try NCLEX review courses. We've had some that have also even contacted nursing programs in their area to see if they could audit some classes or so there's different options, but I would say try to stay in the healthcare field. Try to get your foot in the door. And we do see a lot of that. Like I said, nurse techs, nurse aides, certified med techs, and lean on the institution to sort of help you with that. Because many, when you think about, if you're unfamiliar with the US healthcare and kind of what happens, many hospitals will provide scholarships to individuals that want to become a nurse, right? So that's a way, if you have that healthcare experience, that they may be willing to engage with you and hire you on and then try to help you on that journey. And then you'll be able to work with other nurses where you might be able to gain some of the skills or knowledge that you need that may help you take the exam, pass the exam.
Thank you. So lots of great practical advice coming from the panel.
I'll add one other point. I think Lori's spot on about ways to approach it. It's obviously much easier if you already have U.S. Work authorization, then you just have to worry with the licensure part. You don't have to worry with that immigration part, which is really the biggest bottleneck and barrier for most internationally educated nurses. So in addition to everything Lori was saying, I'd also add there are a lot of resources for nurses who are in the U.S. who aren't licensed yet. So for example, there's the Welcome Back centers. There's one in Boston, there's one in Philadelphia, there's one in Colorado. There are others as well that provide support in navigating nurses who are in those states on their licensure journeys. And they generally have relationships with their applicable state board and can help you navigate that process. And then, of course, there are other opportunities as well that Lori mentioned. So I think just looking and trying to find what resources are available where you are could be very helpful with those challenges.
Yeah, that's good advice. And we work closely with the Welcome Back centres, and we actually have a representative from Puget Sound Welcome Back Centre on one of tomorrow's panels. So yeah, they're definitely a great resource for people in the community. I guess the topic that we've sort of skirted around, and it's a difficult one to answer on the call, but it is the immigration and visa question, and I know that's something that's out of everybody's control. But there was a call earlier in this session for perhaps the visas for nursing, for healthcare to be treated differently from other visas. Do you think there is anything that we can do as a community to come together and to effectively make that case to government about the need for the need for nursing visas, and the fact that it's in everybody's benefits as residents of this country?
Yeah, if I may on that,
Sure.
I think there's a lot that we can do and that we are not doing. I think, especially nurses, right? And nursing organizations and recruiters and organizations like ours that are involved in this process. I think we have to have a stronger presence and voice in Congress, towards the administration. I think there's a lot that we can do much better together, collaborating, speaking with one voice, showing that the problem exists, the problem is real, and it cannot be solved simply with one silver bullet. There's no silver bullet here, really. So, for example, there is bipartisan legislation on this in Congress that's not moving, right? And it's not moving because of many issues. I'm not revealing any secrets here that, the political climate is not the most favorable for bipartisan discussions, right? But there are some, right? And they are not moving because of many issues, but I think also we're not making the pressure that we should make, all of us, and that includes the employers, the hospitals, the health systems. It includes the recruiters. It includes the nursing professional associations, the credential verification agencies, to really show Congress, especially in Congress, but also towards the administration, that this needs a fix now, not just in 10 years time. It's now that the immigration. There's also a question that we didn't focus on, which is the immigration process itself, with the interviews, all the backlogs, and there are probably solutions that do not necessarily address all the issues, but create efficiencies within the process itself just to make it easier, And I think it's a question of priorities. What are you prioritizing when you are processing those visa applications, and how are you allocating resources in terms of border patrol or enforcement or immigration or consulate action? I think if priorities are redirected to solving people's problems, I think things can go much quicker.
Thank you. Yeah, there's things we may or may not be able to influence, but if I look at the organizations that are represented in this symposium, we've got some of the most important organizations in US healthcare taking part over this 2-day event. And I would love to think that we could come together as one voice and make that voice heard and represent the industry, but also represent the public here in the US on exactly this need that's been identified through this event. So hopefully we can continue the conversation afterwards and see whether anything can be done by working jointly on this.
And Sharon, I think the one thing that I agree with everything Rodrigo said. The one thing that I think our colleagues, they're so right now, the hospital and the health systems are so preoccupied right now with what the new bill, the OBA bill, is going to look like, because the implications start in 2027 for them. Many of them are scrambling, trying to figure out how those cuts are going to really impact them. And that has just kind of derailed a lot of their ability to even focus on anything else. We've asked them to participate with us, or here we have this, we would like you to help us with lobbying. And we asked about H-1B, or we've even given them here, take this letter, sign this and send it to our congressman, or do whatever. And there really are so many issues, especially because they're going to hit their rural hospitals. And so I think the thing that Rodrigo said, there's so many competing interests for the health systems that has been one of our biggest challenges with our health system partners.
Yeah, they just don't know. They don't know which fire to put out first.
Correct.
Challenging times. Any final thoughts from the panel? I'd love to finish on a more positive note than too many fires to put out.
Well, I'll just say, on the politics front, it's tough because we were talking about, a combined voice, but I've obviously talked to many stakeholders who are deeply caring about nursing, who have different perspectives on this issue, largely based on, I would say, two pieces. One is the labor rights issue and making sure that nurses are paid fairly and adequately, and what the impact of internationally educated nurses could be for them. And the other is on domestic nursing workforce investment, and ensuring that we're not doing enough, clearly, to ensure there are enough seats in nursing schools and enough access for nurses who want to get into the profession here. And so I think whatever solution ends up being, it's going to have to address kind of a multifaceted nursing workforce strategy, ideally, rather than just focusing on kind of this piece, which has, unfortunately, is being dragged into a larger immigration battle. But I know you want to end on a more positive note. So I would say more broadly, what I think is really exciting is being at this panel. I've just been enjoying to hear all the different perspectives people bring, the prior panel as well, and that people are so excited and interested in learning about, issues around nurse recruitment is really, really exciting. I think what's challenging in the space for those of us who've been here for a while is that it seems like the issues are the same. Like, I remember talking about the nursing shortage 12 years ago, and people remember talking about 30 years ago. And so that can be challenging, of course. But I think the other part is that, it's a lot of two steps forward, one step back, but there is progress too, right? There has been kind of an increased emphasis on how regulatory authorities like boards of nursing can be responsive to the needs of nurses. I've seen those improvements over time. Groups like Michigan Language Assessment are now offering a test that can be used by people doing visa screens or visa keys or other worker certificates. So for years, there was only a couple choices that people were limited to in English. There are more direct hire firms and staffing firms to pick from that can meet different nurses' needs. So I think, there are a lot of challenges here, but there is kind of a positive arc, and the availability of options and resources for internationally educated nurses who are looking to come to the U.S. as part of their career journeys.
Thank you very much.
Piggybacking on that, there are a lot of jobs that are still being placed. We have several clients that are continuing to place jobs. So a lot of our hospitals still see international nurses as a key strategy for their workforce solution.
Fantastic. So there are still opportunities available for people. Excellent. Well, I would like to take a moment to thank our panelists, to thank Patty, Laurie, Rodrigo, and McCall. Thank you so much for sharing your time, your knowledge, your wisdom, your advice with everybody who's taking part in this panel 2 of our symposium. A big shout out to Dr. Fernando Flurkeen and the Michigan Language Assessment team for organizing this event. The event will close now for today, but we continue again tomorrow when we'll discuss 2 other broad topic areas. Recordings from all the sessions will be shared with registered participants, and we'll also do our best to pull together some helpful follow-up information as well for people, because there's obviously lots of calls for advice and information for people out there who are looking to come and apply into the US to work. So we'll try to pull together some useful information, and we'll also carry on working together as a community to help and support people who are hoping to come to the USA, and at the end of the day, who are then helping people who live in the USA by providing excellent patient care to people across the US. So thank you to the audience for your great participation, and I wish you all a pleasant day, a pleasant evening, and we look forward to seeing many of you back tomorrow. Thank you very much.